quick prompt. What was a motivation for you to become an HIV scholar and researcher? So I'll just, for the sake of starting us in a round, I'll start off with Lindsay, just because she's first in my row of squares.
Hi, my name is Lindsay Batik, and I am a third-year PhD student. I'm also in the FNP program at the School of Nursing. I'm also a naturopathic doctor, and my background is working with teens and women in Cochabamba, Bolivia, and also in the Monroe County Health Department, and also as a school nurse. So I am motivated to find ways to better equip teens so they have the tools that they need to optimize their sexual and reproductive health. My current research is in sex education policy in the US, and also looking at facilitators and barriers for contraception access for Hispanic teens. Thank you.
All right. Mitchell?
Hello, good afternoon, everyone. My name is Mitchell Wharton. I'm an associate professor of clinical nursing here in the School of Nursing. I'm also the associate dean for equity and inclusion here. My pronouns are they and them. What's motivated me to become an HIV scholar / researcher is primarily not seeing people who look like me or identify similar to me well represented in research. So the research that I have done most recently has looked at African-American men who have sex with men and looking at their sexual engagements with networked technology. And so understanding how and why they utilize networked forms of technology such as the internet via apps or via websites to gain information about sexual behavior in terms of their networking, but also in terms of their HIV prevention and HIV care regimens.
Thank you.
Thank you.
Rose?
Yes. So thank you so much. My name is Rose Muheriwa. I'm originally from Malawi, and I'm a postdoc in the INSHHR group. My background is I'm a nurse and midwife. So what motivates me in HIV research is my passion to work with young adolescents. I find that we are not reaching the young adolescents with the information, particularly sexual and reproductive health information. And we find that most of the young adolescents are not given that particular information, and parents, communities, religious institutions, all of us and so actually globally, we are not reaching the young people with sexual health information. And I find that to prevent HIV, we need to start with the very young adolescents, and I'm talking about the ages 10 to 14. Thank you.
Before I can move on to the next panelist, I've gotten notification from Nate that you should be able to turn on your videos. So I'm wondering if people can give that a try before we, oh, fabulous. And it's so joy. I'm also really thrilled to see your faces. Thank you. Oh, wonderful, wonderful. Okay, great, we can move on. Martez?
Hi, everybody. My name is Marta Smith. I am currently a doctoral candidate at the University of Rochester School of Nursing. I'm actually a licensed master social worker by training. And so my experience that led up to me actually pursuing my degree, my master's degree in social work, was actually my personal lived experience living with HIV. So I've been living with HIV since I was 21. I'm now 30, so it's about 9 years. I always knew I wanted to pursue a career in research. I just didn't know, quite how that would come to fruition. And so throughout my experience, kind of becoming more passionate about sexual health, especially sexual health for LGBTQ people of color in urban settings. I think that really kind of was the driver just for me to kind of pursue this career. Right now, I'm working on my dissertation research, and that's actually examining sexual health communication among Black and Latinx men who have sex with men here in New York City's houseball community.
And Faith?
Hi, everyone. My name is Faith Lambert. I am a sixth-year PhD student or PhD candidate at the University of Rochester School of Nursing. And I also graduated from the FNP program in 2020. I'd say that my motivation for studying and researching HIV came from my experience working with patients and personal experiences transitioning out from pediatric to adult care, and recognizing that minority populations are struggling the most with making that move from pediatric to adult care. So I just wanted to explore that within the HIV population and see what I can help to do in improving that move.
Thank you. Danny?
Hi, I am Danielle Steiner. I am an assistant professor here at the University of Rochester School of Nursing. I also serve as an assistant director for the Life Sciences Learning Center, which is a science outreach center at the university. And I have a background in infectious diseases, more so in biomedical research. So I have a little bit of a diverse background in what my program of research is focused on. I really have a passion to work with youth, and I'm really motivated in helping the general population to be able to find science more accessible. So really the passion that I have focused on infectious diseases and specifically HIV came from early experiences and different personal interactions I had throughout my childhood and my early time in high school and college, where I decided to do a research investigation abroad and see really globally what was going on as far as different research enterprises around HIV. It really motivated me to think a little bit earlier in the pipeline and think about ways that I could assist youth in really feeling empowered about learning different health literacy skills to address some of the issues we were seeing with the spread of HIV infection.
Thank you. Chen?
Hi, everybody. I'm Jim Mcmahon. I'm an associate professor and
Jim, I'm sorry. I actually said Chen.
oh, I'm sorry. Go ahead.
Yeah, I was saving you for last. So if there's a reason for that. So hang on for a second.
Okay.
Okay,
Chen.
hi, my name is Chen. I'm assistant professor at School of Nursing. My research interest is develop and implement behavioral and biomedical intervention to help groups that have been socially marginalized. Speaking of the motivation to become an HIV researcher is when I started working with HIV research. I started to start with my master's study. By that time, I participate a few research projects that exploring risk factors for groups that has been socially marginalized, like female sex workers or people who practice unsafe sex. And the more I studied, the more I understand that we cannot claim the victims for their risky behavior because there are so many factors that determine their risk profiles. And most of the time that practicing risky behavior is not their own choice. Rather, the behavior is like a consequence of multiple factors that embedded in their life content. So that's why I determined that devote my career in HIV research. So right now I am my research is trying to explore facilitators and barriers related to PrEP use because it's a tool can empower these people from HIV prevention. Thank you.
Thank you. And last but not least, Jim, but I was also hoping that after your introduction, you could segue into explaining what INSHHR was. So this is why I saved you for last.
Okay. I appreciate that. Yeah, I'm Jim Mcmahon. I'm associate professor here in the School of Nursing. And I guess what motivates me, I can sum it up in one word, and that's equity. Because like most other health conditions, HIV affects the most marginalized and vulnerable members of society, and that's not by accident. There's a reason for that. As Chen was explaining, our structures are really set up that way. So you think about discrimination, lack of access to information and services, lack of insurance, all of these things kind of add up and contribute to health disparities that really affect, disproportionately affect low income and often racial and ethnic minority communities. So what motivates me is the hope that my research might contribute to improving or promoting health equity, at least in terms of HIV. I should say that two members of our group are could not be present today. That's Doctors Natalie LeBlanc and Hugh Crean. So they couldn't make it, and I'm going to now give you a very brief sort of introduction to the group, and I'll put up a link to our website. We have a website, so you can click on the website and also read up on what research that Drs. LeBlanc and Crean do as well. So the INSHHR group, School of Nursing, Interdisciplinary Sexual Health and HIV Research Group, as we're called. We established the group in 2014. And at the time, we realized that there were a number of faculty and students that were working in the areas of sexual health and HIV. And we thought, it might be a good idea to formulate some kind of a more formal group to kind of take advantage of our combined experience and interdisciplinary training and expertise, and sort of share our pooled knowledge and try to increase collaboration. And I think a real strength of the group has been its interdisciplinary nature. In fact, that's why we named the group the Interdisciplinary Sexual Health and HIV Research Group. And although our members have changed over the years since 2014, that interdisciplinary nature has always kind of stayed. And so we have a variety of different disciplines represented even in this group here today. Nursing, of course, but we also have people with public health background, psychology, anthropology, epidemiology, immunology, social work. And so it's just really a strength, and it's really cool to meet with people that have these different backgrounds, these different perspectives, bring different methodological perspectives and sort of tools and viewpoints into the group. And I think that really inspires and increases innovation and advancement in the group.
Thank you. So the way we were going to lead this discussion is I have several questions that I've posed to the group that I'll prompt beforehand, and we're going to open this up as more like a popcorn. So just, whoever is inspired at the moment to respond to the questions, and we'll try to get them in within a good range so that we have time to open up to anyone who's watching. If they have questions, they can use the Q&A feature, and then Nate will pose those questions towards the end of our discussion. And then we'll finish off with just any last thoughts that our panelists want to share. So just to start off with the first question that I had, and what I was thinking about was anyone who's kind of been alive during the time of the early, when AIDS came onto the scene in the 80s. And there was just, the stigma was just so rampant to the effect that we couldn't even have our president and administration, say the words AIDS, and it affected so many that you have populations that you have affected, but it really affected all of us as a society in the way in which we perceive HIV and AIDS. And so I'm curious in that timeline, and since you all have become HIV researchers and scholars, what are the stigmas that continue to exist? And then what have there been any stigmas that have been demystified over the years concerning HIV and AIDS?
One thing that I can say is that I think, stigma continues to exist, and we can't pretend that it doesn't. But I think it shouldn't exist at all, and right from the beginning, it shouldn't have existed. But we know so much more now about this this disease or this health condition. It's a viral infection, like any other viral infection. Like hepatitis or anything else. It's now a chronic disease, so it's no different. Having HIV is no different from having diabetes or any other kind of a chronic disease. People who are undetectable, that is, that they are adherent to medication and the virus can no longer be detected in the bloodstream. It's impossible to transmit the virus sexually. I think that in all the studies that have been done over the years, I don't think there has been even a single documented case of sexually transmitted HIV when a person has been had an undetectable viral load. So we should really treat this just like any other health condition, and there's medication for it. It's controlled. There should be no stigma around it. I don't know how others feel about it.
I would agree that there should not be stigma around it. However, stigma still continues to exist, particularly in those marginalized populations. So when we think about some of the policies that we have in place or are lacking, when we think about intravenous drug use, the entire premise of intravenous drug use has stigma associated with it to begin with. And so layering that on top of thinking about how this can be another mode of transmission for HIV creates stigma for the individual, but also on a societal level in terms of when we're thinking about investing in programs from a public health perspective, how do we move these agendas forward to show that we are actually doing harm reduction for folks rather than enabling people to engage in what is considered an illicit substance abuse. And so it's things like that that still make it very difficult to make inroads, even on a local level. And excuse me, across the world, there have been a number of places where there have been successful demonstration projects for needle exchanges and other types of opportunities to help destigmatize it, but yet the stigma still exists. And so that's one example. The other one that I was thinking of is we still conflate sexual behavior with sexual identity. And that continues to be a very huge area where people are stigmatized, particularly, I'll speak for the population that I'm most familiar with, I won't speak for others, but in the African-American population or the Black population, that continues to be a heavy piece. While we think that there have been tremendous strides in terms of recognition and awareness for sexual identity, LGBTQ populations, there still exists a lot of stigma within certain subgroups or certain other specific groups, particularly racial and ethnic groups. And so what being out looks like in one particular racial category is not the same that it looks in another. And along with that comes the idea that people are risky, or people are, I think that's the word that I want to use, yeah, are risky, rather than there are conditions which put people at risk. And so there's kind of this idea that it's the person and not kind of the disease that's the problem, or that's the issue that we need to be attending to. And so these things continue to get conflated. I still think that there's still stigma that exists within religious communities. And so again, I'll speak through the communities that I'm familiar with. So when we think about the Black church, a very powerful place of refuge and solace, but also hasn't necessarily fully embraced kind of messages that relate to people who are, again, in those other marginalized groups, who may be practicing same-sex behavior, or maybe engaging in other things that may put them at risk for HIV transmission. And so we have these conflicting messages oftentimes. And that's not to put religion or any spirituality or faith tradition under the bus. It's just the reality of the situation. And it's one of those things that kind of leads to us still having these ideas of stigma and what this looks like. And I'll pause there because I can see others have comments as well.
I agree with what you're saying in the sense of and what it looks like in identities. I think one of the things that sat with me earlier on when I was thinking about HIV, and even before I actually was formally in HIV as far as my educational background and everything else, even just earlier in childhood, seeing what HIV looked like in youth and seeing what HIV looked like in different communities in that 80s and 90s era is very different from what I see now as an adult looking within that youth population of what it looks like now. And I think that's some of what I've had a little bit of a reflection about more recently in how youth are seeing things. When I was younger, there was a big thing about if you had HIV, there was a stigma of what you would physically look like and this sense of impending doom that you would die right away. And youth had a lot of negative views about that. And there was a lot of misinformation because you didn't know a lot. I mean, you just had the sense of someone's sick. People didn't talk about it. There was a lot of whispering, and there was a lot of negativity around that. And if you wanted to learn something, people would start to question you. And that was something that really stuck with me. But now, one of the things I really trust and I think is important for youth to understand is that it's important for them to question things. It doesn't matter where the question's really coming from. It's just that if you have a question, you should be allowed to get that answer. You should be allowed to start thinking independently. And usually the thought is a youth, your mindset is you're young, you don't know, you're learning. And as adults, we're more on that. We know, we're going to tell you. And I think that that's a traditional way of teaching that really hasn't worked for decades. And it's not just around infectious diseases, but really within sexual health and wellness, that's where we really see a lot of it, really just unpacked in different ways for different youth. And allowing individuals to be curious about what they want to learn and not have a stigma associated with it, I think is important, because now we have Google. You have that instant information source at your fingertips. If you don't know something, you can quickly try to find something about it. And there's that sense of an adult. Do you want your child searching for this on their own when it comes to sexual health and when it comes to HIV? And that sense of if a parent sees their child Googling something, they immediately think, where's this coming from? And there are some youth that are in households, they're in communities, they're in environments where it's not an issue. They're excited. Hey, I'm curious about something. Let me type it in, figure it out. Whereas others might feel this sense of insecurity of, I'm afraid to type this into Google because my parents or my family members might see what I'm searching. And they might think that either I have something, or I might know someone that has something, or I might be doing something. And like what Mitchell was saying, it's that sense of people associating that behavior with the individual and thinking that is that identity, and thinking in the sense of tagging people as you're being risky. And that's really that area we don't want youth to go down. We don't want them going down that path. We want them to think, find information. If you don't know it, find information and let that information guide you in making decisions about your own health, wellness, and whatever you want in your own lifestyles. But letting that information and knowledge be empowering so that they feel comfortable. And seeing that, I think, is different, seeing youth navigating some of that now versus when I remember when I was part of that younger group, and seeing what things looked like in the sense of HIV. I think now there are so many tools and resources for youth to use. The problem right now is really access to it and awareness of it. And I think that's one of the stigmas we have to kind of get that hurdle so that there's more uptake of that.
You're bringing up, both you and Mitchell bring up, I think is important to connect that with stigma is shame. And I think that's why it's important to unpack and dismantle stigma, because with shame shuts us down, right? And it also disconnects us. So as I'm listening to you speak, Danny, I'm also thinking when you have shame, you also disconnect from your community and you do all this in isolation, as opposed to without stigma, without shame, we connect, we collaborate, we share information and resources. And how much richer does that lead to when it comes to people connecting to the information that's pertinent to their health, right?
There, in addition to what the other just said, there's also some stigmatized episode during the HIV prevention. For example, pre-exposure prophylaxis is a medication to prevent people from HIV infection. That is stigmatized by most people, because people consider people who using PrEP will be, conduct more behavior that may contract to HIV infections. So that make people less likely to using this HIV prevention strategy. And also a study I conducted showed that the more frequent a person go to the HIV services, the less likely the person want to using PrEP, because they encounter some mistrust or stigmatized experiences during their medical care experiences. So that's something we also need to pay attention to.
And just to add on, and another area that is also influencing stigma is our lack of comfortability to be able to talk to the young adolescents about HIV sexually transmitted infections, and all issues related to sex. Because if we don't reach to them as long as they're young and they're growing up with that lack of information, they won't be able to understand what is like really with HIV, what happens and what can be done, and they won't be able to understand that particular thing that is happening in the person who is living with HIV, and they cannot be able to try to also help to prevent the stigma and discrimination. So as long as we are comfortable with conducting research with the young adolescents from 10 years, and we're able to talk to them and at every level, from the family, from the research institutions, from the schools as well, that stigma cannot be navigated.
So I want to go ahead and I'll ask my next question, but feel free to stick with this question if this is the one that you still wanted to drop into. But just I want to also be conscious of time, and then also be aware if there's any questions that have been posed by people who are watching today. And some of you have already alluded to this too, so I think this would be a helpful question to kind of to ask. What have been advances in the field of HIV research and policy, and what gaps exist? So like I'm hearing kind of this gap with trying to make that bridge between stigma and HIV and how people understand HIV. But the gap that seems to exist is that it's disconnecting people from the actual resources and the advancement of PrEP, right? And then also somebody just blanking out, mentioning about, or Mitchell, when you were talking about needle exchange, right? And how needle exchanges can be a helpful public health policy, but the gap is the perceptions, right? Of how people have these misperceptions or ideologies around what this facilitates, what needle exchange facilitates. So I'll just ask that again. And what have been some advances in the field of research and policy? But then what are the gaps that still continue to exist?
I actually wanted to say that from the education side, in a sense, because it's both an advancement and also filling more gaps in a sense, and creating and identifying more gaps. But sexual health education, it really started off in that general sense, really focused on preventing pregnancy and thinking more in tune with that alignment of what we're educating youth about. But more recently, a lot of states have actually put out mandates that require their students to be taught about sexual health, and specifically some states require they have to be taught about HIV. And that's a really big lift, because by putting it in the educational standards that have to be done as far as a mandate, schools have to talk about it, regardless if a teacher feels comfortable about it, regardless if the school community supports that, regardless of what the parents may think, the school has to offer it. Now, granted, policies in place in many states, parents can opt out for their students to get that information, but then there are also more policies in place now for youth to get empowered to be more in control of the information that's related to their sexual health. And in many communities, the youth can actually decide, I'm going to go and get that information on my own. And I think that's really, really powerful as far as an advancement. But I think some of the gaps associated with that is when it comes from the school and the educational institutions that are providing these different types of resources for youth as far as their sexual education, HIV education, a lot of the information is not, it's not fact checked in some ways by science communities, medical communities. So they don't have to necessarily be medically accurate information that's being shared. They don't always have to be inclusive, whether it's culturally inclusive. They don't have to be tailored in the ways that they're sharing information with youth. And I think a lot of these things are creating gaps where some communities are great at what they're providing their youth as far as sexual health information and HIV prevention information. And other communities, there's a big void about what's being missed and what they're not getting access to. So I think that's both talking in the sense that there's policies in place that are helping and they're really good at we're getting them in place, but there's still a lot to be done.
I think in terms of HIV prevention, I think among the biggest advances that I've seen is just increased tools in the HIV prevention toolkit. So when I started doing this work in the mid-90s, basically all there was behavior change in condoms. And now, since then, we've added new tools. We know that treatment is prevention or treatment as prevention, or what we call U equals U now. As I mentioned, that if a person living with HIV becomes undetectable through adherence to antiretroviral treatment, then it's basically impossible to transmit HIV to a sexual partner. And as Chen was mentioning, we now have pre-exposure prophylaxis, which is an oral daily medication that is nearly 100% effective if taken as directed for preventing an HIV negative person from becoming infected. And so we have a lot more tools in the toolkit. I think the flip side of that is the gap where, as Danny was mentioning, we need more education, because the awareness around all of these tools is really, really lacking in some groups. And I think that in part, that's because a lot of providers just don't want to talk about these issues with their patients. And so the knowledge of these additional tools is, I think, it really needs to be addressed as a gap.
I think there are two things when we're talking about advancements in the field, and one of them really isn't an advancement. One of them is just kind of an update. So the United States has had a national HIV/AIDS strategy for years, and we revise it every couple of years. The newest edition has just come out for 2022 to 2025, and I'm going to put the link in the chat. But as we think about what are some ways in which we can, sorry, can't talk and type at the same time, sorry. As we think about some ways in which we can kind of start to mobilize and collectively organize around some of these things, this is one way of doing it. Now, this is the US strategy. The World Health Organization has a strategy as well, and various countries have their own implementation strategies. But what's interesting here is a couple of things. So for the first time, the person who is overseeing this is a out and HIV positive person, which is quite remarkable, Harold Phillips. The second thing is that it shows that there can be some not only institutional but kind of government infrastructure that can be built around this if we utilize it correctly. The second thing that I'll talk about, and I think Chen may have mentioned it, and I think Jim may have mentioned it as well, is that is when we think about providers in terms of their roles in providing information, in particular around pre-exposure prophylaxis. There is recently an update to the, sorry, talking and typing at the same time doesn't work well. Pre-exposure prophylaxis for the prevention of HIV infection, there's an update. And what's interesting about this update is it really goes in really deep and really specific. I think this is for the first time that it clearly explicitly states that PrEP should be available for all persons, which hadn't been the case before. So it would talk about men who have sex with men or transgender women, but it really didn't have a whole lot in terms of biologically, women who were born women at birth. And so this one really kind of addresses that and helps people to figure out which formulations of PrEP are best. It also talks about some of the more controversial forms of PrEP, so on-demand PrEP. And then it also looks forward. So we know that an injection-based pre-exposure prophylaxis is coming soon. It also talks about thinking about that as we near the time when that comes. And I think all of these things are great. What it still doesn't address is some of the specific gaps in terms of things that had not been taken up by a lot of areas throughout the country, and that was the expansion of Medicare. And so when we again think about where the areas that are being hardest hit with new infections of HIV in this country, it's traditionally in those areas that didn't opt for Medicare or Medicaid expansion. So we're thinking about the South and some places in the Midwest, and we're seeing those numbers increase. And that's we're not doing enough. I shouldn't say we're not doing anything. We're not doing enough to really work towards getting people into care, keeping them engaged in care, because treatment is also a form of prevention. And then thinking about the more traditional forms of prevention, such as pre-exposure prophylaxis.
Lindsay, Faith, Martez, Rose, I wanted to also pull your voices into the group, so I wanted to see if you had other thoughts to share, and you can respond to either questions.
I have a couple of thoughts I could share just as I'm listening to the group with all these wonderful ideas. In my research, I'm thinking about people sometimes that, I'm looking at like Hispanic teens, and I'm thinking about sex ed, and I'm thinking about if they're in a migrant working family, they're moving frequently, and they might miss that section or that month module on sex ed that's offered in a health class, that maybe they aren't there and then they switch schools and they just missed it completely. And how that disparity is kind of something, it's like the people that aren't in the seats at school for whatever reason, whether maybe they're absent or maybe they are in ISS for whatever reason, maybe they're at the nurse's office. I don't know. There's a lot of reasons that you can actually miss the sex ed if you're actually in a district, in a state that offers the comprehensive sex ed that's needed. And then another thought that I wanted to share is kind of disparities in care that's provided in like a primary care office. A lot of times the population that I'm looking at, they don't see the doctor that often, right? So when they come in for a visit, there's priorities that they need to cover, and it could be something more acute that kind of takes up that time. And so it might not leave the time that's needed for, to talk about their sexual reproductive health that maybe isn't an imminent concern, yet it is very important and could really affect them over the long term. So
this is all pending a physician that will actually say these things or actually talk about them.
Right. So it's like way down the list sometimes. And I think I've even been in situations as a student where I'll say, maybe we should discuss this. And they're like, no, we just don't have time in this visit. And I wonder when will that person be seen again? I mean, it might be a really long time.
Yeah. Wow.
I think you made a great point with that too, in the sense of like that comfort and from the patient side of it too, when you're looking at youth, how much do they need to have that time before they might say the words that they're asking? They might need that longer type of a visit, and knowing that it's just such a short time, they might not get to that comfort level to really disclose or ask certain questions that are important. I think that's really key.
I was actually going to say the same exact thing that you just said, Danny, which is quite funny. But yeah, the comfort level of the patient, especially looking at some of the things that I've looked at in regards to providers, some providers don't bring up sexual health concerns unless the patient actually starts talking about it. So if that patient isn't there yet or doesn't know how to express their needs in regards to their sexual health, that conversation generally won't happen.
In my minimal understanding, I've also had an understanding that, if you have language, right? So language or literacy barriers, right? And then not everything is translatable to English, right? Like people that I've known from who have, other languages that as a primary language, they often say that like there's things that just get lost in translation. And then there's also things that just don't come out, in the same way as they would in English. And so where does that's that additional barrier, right, as well, where, not even the physician's making that bridge to have this conversation, but then where does the conversation land when there's a significant language barrier and there's not even language to emerge at, and then add on the stigma, right? So it's kind of this constant navigation of how do we think through these barriers so that we can, right, start creating those bridges for the information to flow at all levels, right, at multiple levels. Martez, I apologize. I feel like you were about to jump in just as I spoke, so I apologize for, but
Oh, no problem. So things I'm really interested in, like systems level stuff, like structural level things. And one of the things that I've been following very closely is the HIV criminalization laws. And so there are actually quite a few states here in the United States that have laws that either that are punitive, obviously, in respect to disclosure. So like if you fail to disclose before you have sex with someone that you're HIV positive, or if the courts find there was some type of malicious intent, right? That's punishable under the law in a lot of states. Some states have done some work to repeal some of those laws. Like I think there's been a push here in New York State to definitely get some of those laws repealed, with varying degrees of success. A lot of the more progressive states you've seen kind of like overturn the laws. But what's really why I bring that up is because now we have undetectable equals untransmittable. And what that means is if you take your medicines as prescribed, those living with HIV, they take their antiretrovirals, and they reach viral suppression, meaning that the virus can't be detected by a laboratory test, then the chances of them passing it on to sexual partners is virtually zero, right? And so one of the things that we also know to be true about HIV criminalization laws is that they're actually inversely correlated with disclosure and testing. So I think the people were thinking right back in the 80s and early 90s when they placed these statutes on the books that we would do these because people living with HIV posed a threat to us. Now we knew it wasn't true back then, and we now have the science to back that up. And so I really think it's really important that we kind of continue to critically examine HIV criminalization laws, especially with respect to how we treat our clients and some of the barriers that they may be facing. There are actually quite a few people that I've talked to personally who do not want to disclose their HIV status to folks or sexual partners out of fear that they'll be prosecuted, right, if folks find out their status. So I think if we really want to truly see, an HIV-free future, that's one of the things that we also need to continue to tackle.
So I'm hearing you wear multiple hats, right? You're scholars, you're researchers, you do this work for getting in the essential information out to the field of practice, but you're also advocates and you're activists in other ways because of the ways in which your work stimulates the possibility of disrupting policies that create harm, policies that disconnect people from the information and the care that they need, right? And also can shift practice. I think that's the other essential part to where your work can be a form of activism, right? How can you interrupt the kind of status quo of practice so that practice can be reconvened in a way that really is demonstrating the fullness of care, I like to think of it as the ethic of care, right? So that you really are tapping into all the essential things that impact an individual's life from a multi-tiered level, right? Not just information, but also about what's going on in their education, what's going on in their home life, what's going on in their intimate partnerships, right? And just kind of that kind of bio, I'm going to mess it up. So this is where I reveal I'm not the clinician, right? Biopsychosocial, right? Spiritual aspects of human life. I would love to turn it over to see if there's any questions from our participants, but we can also continue our conversation. And just, again, you can either respond to the previous questions, but I'm also interested in thinking about what might be some essential takeaways that you want people who are watching this to know and understand, just ultimately about HIV, but whether it just be also about how policies and practices affect the communities that are and when we talk about the communities that are impacted by HIV, we're really talking about all of us, right? We're talking about all of us as a society, and I think that's might be something critical. But specifically people who are impacted by it because of this as a diagnosis, and because of this as how they have to live and navigate their worlds. So Nate, I want to turn it over to you, see if there's any questions from the Q&A.
Yes, we have 2 questions so far. First question, Descovy, Truvada, and Biktarvy, 3 prominent PrEP options, are all owned and produced by Gilead Sciences. Are there ways we should be safeguarding access against potential IP monopolization of these critical treatments?
Yes, yes. Gilead actually, I don't know if the lawsuit is still ongoing or if they settle it, but they actually had a lawsuit filed against them because it was found that they were actually withholding a safer version of an active ingredient, right, in a lot of the HIV medications. It was tenofovir, right? So there was one version of tenofovir that was found to be more toxic to, like, your kidneys, your liver functioning, that they had apparently found over a decade ago. But they went with, and instead of going with the safer formulation, they went with the more toxic formulation that was discovered. And so folks filed a lawsuit against them. And just so to more directly answer your question, yes, I do think there are ways that we should be safeguarding against that monopolization. The first of which we should definitely be promoting generics, right? I know, I'm not sure of the current status right now, but I know for the longest, like Descovy, Truvada, Biktarvy, the recipes were super safeguarded by Gilead. And they were pretty much protected from sharing information that would allow other companies to make generics of these drugs. That's also led to a lot of complications in terms of folks getting access to PrEP, right? And we already know like how our structures are set up, right? They're racially imbalanced, they're imbalanced in terms of class and income, and they're imbalanced along the lines of gender. So the folks who really, really need these medications are oftentimes locked out. And you kind of have this monopolization situation, making everything that much more complex. So I know there are a few different advocacy groups that have been working together to kind of like call Gilead and other pharmaceuticals out on their stuff. And so I don't have that information off the top of my head, but what I can do is I can find it and then share it in the chat.
Okay, thank you. Next question we have is there change in the field of HIV/AIDS after the emergence of the COVID pandemic?
I would say, kind of going back to my corner of the educational side of things, for youth education, there's been big changes because of what's been going on with the pandemic, with education for a while going completely remote for some populations. And because it's not a standard across the states as far as sexual health education and HIV education, a lot of youth have had a halt on their education as far as HIV prevention education. And some have found creative ways to go online, others haven't. And with some schools having different policies as far as how they can prioritize their in-person time and whether they were cycling between some classes they could have in person and other classes had to be taken remotely. There's definitely been a hierarchy as far as what the priority is in education. And unfortunately, HIV prevention education was not at the forefront as far as getting that to youth during the early parts of the pandemic.
It's interesting to note that in 2020, there was actually an increase, I think about a 30 or 40% increase in the number of new HIV diagnoses in Monroe County. We can't exactly link that with COVID, and one might expect maybe that new cases of HIV might have gone down because of COVID, because of social isolation, but they've actually increased. And so have other sexually transmitted infections as well. So I think if we were to link that to COVID at all, it might be due to the additional stress. I know a number of cases have been linked to increase in injection drug use that has occurred, increased use of alcohol and drugs throughout the pandemic as well. So the COVID really intersects with HIV and substance use and mental health issues as well.
I was just going to say, this is such an interesting question. So at the national professional level, I think many of you know that I serve as the president-elect for the Association of Nurses in AIDS Care. And so we recently had our conference in November. One of the things that we have been talking about for the last 2 years, amongst many things related to the pandemic, is what lessons can we learn from the pandemic, but also what lessons should the pandemic be taking from the early days of the HIV movement. So I think that there's this kind of retrospective analysis thinking in terms of what could we learn, how can we kind of move forward, but also what can we do to move things forward with the HIV epidemic. One of the questions that we hear a lot is, we turned around the vaccine for COVID in less than 20 months. It was probably like 12 months or so. What's the holdup with regard to HIV? And so one of the things we have to recognize is that it's a much more complex virus in the way that it acts and interacts with the body, different forms of mutations, those sorts of things. But it's cool. If there's anything that's good that comes out of this, it's good to hear that the public is really kind of raising awareness and pushing the envelope much the same way that they did in the very early days in terms, well, maybe not the same ways that they did in terms of ACT UP, but there's a much more concerted public opinion and public investment in where we're going with regards to HIV treatment and prevention. I do want to circle back to one thing that was mentioned in the previous question, and that was as we were talking about the formulations for PrEP. So Descovy and Truvada are definitely for PrEP. Biktarvy does not yet have an indication for PrEP. It is an HIV treatment medication, but it does not have an indication for pre-exposure prophylaxis. Excuse me. So I just wanted to clear that up as we were talking. It's the clinician / researcher / activist in me.
Thank you. So it looks like we have another question from our panelists. And after that, I would love to, because we have about 5 minutes left with our time. And I just want to segue from that question to just if there's anyone that wants to, any last takeaways that you would like people watching to know and understand, or just, what are your last thoughts? If you had that one mic drop that you wanted to say before we part today, what would it be? So Nate, if you want to just read the question in the chat.
Yes. Critics say that the focus on HIV prevention is not as robust now that the group at the forefront of transmission is Black women, as opposed to gay white men when the disease was new. What is currently being done to combat the issue in this population? And do you have any ideas about what more can be done?
So if I'm understanding the question correctly, what more can be done to stem the increased infection against Black and Hispanic women as opposed to other groups? Is that the question, Nate?
Yes, I think the question is, what is currently being done to combat the transmission of HIV to specifically Black women, and what more can be done?
I think one thing that I've seen is, so like now we kind of living in like the biomedical prevention era in terms of HIV. So the biggest thing has been trying to like get folks into clinics and promote pre-exposure prophylaxis for HIV, which is a pill that you can take once per day to prevent transmission or prevent, from contracting HIV. But I think what the issue is that, and I mentioned this earlier, is that our structures are biased, right, in terms of race and in terms of gender, right? And so Black women now kind of being at the forefront of new infections, or being, right, a group that is definitely concerned because the numbers are consistently increasing. From a structural and from a systematic standpoint, we're kind of at odds ends, right? Things are working against us. And so I think one of the things, me personally, I always say is that we shouldn't just be focusing on biomedical prevention. We need to look at things from a structural standpoint. We need to look at things at the community level. And we also need to look at individual and intrapersonal, right? Things within people. And if you live in a society and a structure that consistently negates your humanness, right? Humanity, right? I can only imagine I know what my lived reality is as a Black gay man, right? So I can only imagine what a lot of Black women in the United States face in regards to sexual health and prevention. Again, as someone mentioned, like having sexual health education in schools, that needs to be pushed. Again, I think that gets really complex because of political reasons, right? Which we know does not do anything. So if you really see a shift.
I really agree with what Martez was saying. I think he's that comment of just really, that really is hit a couple points that I was thinking to reflect a little bit more on, in the sense that even with the youth and in the education and focusing on that with Black women is important, but just going backwards a little bit further to just research. And a lot of that bias has been made towards a certain population or just many other populations, I'll put it that way, that don't include Black women. And because of that, Black women, when they see the data, a lot of educated women reading information, trying to stay up to date on things, say that doesn't reflect me, that doesn't apply to me. And I think that's really a big issue that has to be overcome by providing more data that reflects different populations and kind of getting a little bit more inclusivity in the types of research that's being done. And even realizing that Black women are not one entity. There's a lot of diversity within Black women. And being able to look at data coming from a variety of sources, I think will help more individuals feel a little bit more comfortable with the different types of treatment, prevention, therapeutics that are coming out and that are already available, but understanding how it relates to me in that sense of how we are as individuals. Does it connect to the individuals that are requesting it, that want to learn about it, that might use it, and making sure that the research investigations align with those things, and that the data, once it comes out, is also translated to the community so they can understand how to interpret that information that pertains to themselves.
Thank you. Well, we are almost at the end of our time, so I just want to thank all the panelists. I want to thank anyone who's attended, and then most especially, I want to thank Nate Blumke, my co-conspirator from the Student Services Office, for helping to get this webinar produced. And I just want to open it up for kind of another popcorn round of what is one last thought that you'd like to share with our audience before we part ways.
I think you'll hear a lot in the news globally, nationally, that the HIV incidence is coming down. In New York State, the incidence of HIV has reduced by about 10% in the last 5 years. Globally, it's about 30% in the last 10 years. But that gives a kind of a skewed picture, because if you look at the certain groups that we've been discussing today, it's basically stable. And the groups that are coming down in incidence are the groups that it wasn't really very high prevalence to begin with. So sort of, we still have a lot of work to do in terms of health inequalities and addressing social and structural factors that perpetuate the pandemic and the epidemic.
I think if I had to leave folks with anything, I'm super passionate about youth. I'm super passionate about sexual health education and just comprehensive education in general. If we could advocate for comprehensive sexual health education and gender education, right, in schools. I think ideally, right, given our structures begin to change with these shifts and these pedagogical shifts as well, I think we could really begin to see some really impactful changes in the near future in terms of HIV incidence.
And I echo what has been said, and also piggybacking off of what Martez just said, as far as the youth, but even in a broader sense, getting community involved in the research enterprise, really having community inform the research design, having community inform the way research is being conducted and how it's being reported back out, I think is really important, because then it will allow for a better engagement in the sense of having that representation within different types of research studies, broadening that to be able to have really information that can be used to inform and to guide our general nation's health by having everyone at the table.
One last word. Who wants to have the last word? Go ahead, Rose.
Yeah, I feel that it's very important that we all need to have mindset change in terms of sexual education to young adolescents, particularly those from 10 years to 14, just because we need a lot of consent for parents, for researchers like us to be able to get access. And also institutional review boards should be able to be a bit flexible in terms of approval to the research regarding young adolescents, because right now it's like a nightmare to get approval for research concerning young adolescents and sexual health. Thank you.
Yeah. Thank you all again. Really can't, appreciate your time. It's just been invaluable today and all the information that you shared. Thank you to the attendees. Thank you, Nate. And I wish you all just the very best. And, you know, hopefully the impact that you've had today will inspire other people to think about how they can also continue to be activists, scholars, community members, educators that are getting out the critical information about HIV to anyone that's willing to listen and hear and understand this information. Thank you all. Be well.
Thank you, Kristen. Thank you, Nate.
Thank you.
Thank you.